if we try to predict for you what the consequences would be, we'll keep saying it's really hard to pin down, and that's in part because we don't know what the federal government would do in response. So, very simplistic description, there are at least 3 kinds of things the federal government could do in response. One is judges could rule that provisions are positively conflicting with the Federal Controlled Substances Act, and so are preempted and are essentially void. Now, it's a lot easier to predict that there will be court battles about this than to predict how it will turn out, but one guess would be that a state store that's directly selling would positively conflict with federal law, but Washington and Colorado are very different. Under those, the government will only be licensing and regulating, which are activities that they already do with respect to medical marijuana, so perhaps those would stand. The federal government can also hire a bunch more DEA agents and try to fill in for some of the missing state and local enforcement. I said earlier, 97% of the arrests are state and local, and that's true. It's really the sales arrests, though, that matter for industry structure, and for that it's 90% that are state and local. And this chart is to try to give you a feel for that. The bar on the far left is the total number of DEA marijuana sales arrests in the nation. The other bars are state-specific. Blue part is DEA arrests, yellow, state and local. Montana was one of the states that was considering, they're not going to vote on it in November, but had Montana passed, the DEA could easily fill in for what Montana police were doing. Couldn't make up for California. The 3 states that are voting are somewhere in between. The last sort of federal response would be for U.S. attorneys to write letters to landlords or other business affiliates like banks who are accepting deposits. And the letter would say, in effect, your tenant is violating federal law. You better do something about that or we'll seize your building. And those letters have a real effect. They've been used to close down a lot of medical marijuana dispensaries at fairly low cost to the federal government. It's very expensive to hire a lot more DEA agents. Letters are relatively cheaper. Now, I want to use this letters idea to illustrate another point I'd like you to take away from this, which is that the devil can be in the details and the nuances of the propositions. I think it's possible that those letter strategy would work very well at shutting down the Washington proposition, but not Colorado. Because in Washington, each licensee would be required to operate from one fixed and specified physical location that is reported to the state. It's an easy target for letters. In Colorado, the facilities are just entities with no restriction to operate in a particular place. You could grow in a bunch of places surreptitiously, sell out of the back of your car. I also want to use the letter story to make another point, which is that the federal government will face some very difficult choices if any of these pass. Now, let's suppose for the minute the DA is not going to get 10,000 new agents, and there's not going to be a complete replacement of the state and local enforcement, so production costs are going to go down, consumption will go up. If you allow a regulatory scheme like Washington with its taxes and with its other restraints, that could take the edge off of the increase in use. On the other hand, it's exactly that regulatory structure that's relatively easy for the federal government to attack with letters. So that's a tough choice then. On the one hand, the thing that you can attack is the one thing that can take the edge off of the increase. But it might be very hard for the federal government to do nothing because of political pressures. And if the federal government does nothing, then it's entirely possible that other states will follow the lead in a domino story. And there's a lot of reasons why there could be a domino effect. I'm going to give you just one because it'll give me an excuse to talk about potential impact on prices in other parts of the country, which is the last point I want to make. And for this part, I want you to, for a moment, imagine that you are a wholesale marijuana dealer supplying a state like New York. Right now, you're sourcing directly or indirectly from Mexico or maybe illegal production in California. You'd rather buy in Colorado if Colorado legalized. The price would be much lower, lower enforcement risk. Would anyone there sell to you? Well, the Colorado proposition makes it very easy to get a cultivator's license, and there really isn't much in the proposition to prevent diversion, so it's entirely plausible that there would be some people who would get the cultivator's license, produce some to sell to Colorado residents, but also be happy to sell larger quantities to dealers from out of state. And if you run through the math of the cost, both the production and the distribution cost, that system could be providing marijuana back in New York for maybe a quarter of its current price, creating substantial downward pressure over time so that after production ramped up, who knows, maybe 5 years, you could see a very big decline in price. And the Colorado producers would have a big incentive for doing that because the whole US market is 50 times the size of the market inside Colorado. And the Colorado government would in some sense have an incentive to look the other way because they would benefit economically from this export industry, if you will. So if you run through that sort of thinking for all the states, you create a map that looks like this for the percentage decline in prices you could see around the country. And the short answer is declines of 75% or more everywhere throughout the country, potentially leading to increases in use and questions of whether or not that could be dealt with prevention, topics I'll leave to Rosalie.
Thank you, John. So you've heard both John and Bo mention that with these proposals, even just a simple state proposal, legalization can lead to a substantial decline in price. And economic literature, published as well as theories, suggest that with a decline in price comes an increase in consumption. No one, not anyone who's written a single legalization proposal, wants youth to increase consumption. Every proposal has prohibited youth for individuals under the age of 21. So, can we prevent our way out of this, and can we stop youth from using if price is declining substantially as indicated by Bo and John? It's important to understand there is a well-established literature in the US, Australia, the Netherlands, France, that youth consumption of marijuana is responsive to price. A literature review that we conducted as part of the altered state evaluation showed that, in summarizing literature, the average effect of a 10% decrease in price would be an increase in initiation of individuals 18 and under between 3 and 5%. A larger price decrease would lead to a larger initiation. So, can't we prevent our way out of this? We've got drug prevention. Why don't we just do prevention, and that would offset the effects of the price decrease? And that's, in essence, part of the arguments for this. The problem is we have prevention now. And in prevention today, we have half of the people who use marijuana, who report ever using marijuana, initiating before the age of 18. 1 in 4 high school seniors have used marijuana in the past year. 1 in 4. Why is this a problem beyond just youth starting using? Lots of epidemiological research has shown, and here I've shown a graph from some RAND work, that the earlier a person initiates, the more likely they become a heavy independent user. Over 65% of kids who initiate marijuana at the age of 12 become heavier dependent users even before the age of 21, according to our model, where it's cut to less than a third if the individual waits and doesn't initiate use until age 18. So we need prevention to help delay initiation. But as I said, it's not seeming to work, but we all know prevention is a hodgepodge in our school systems today and in our communities. We don't have the best model programs out there being implemented. So what if we just could implement the best programming we have available? Well, because we don't have data on that, RAND constructed a microsimulation model to estimate what would be the effect of being able to implement, according to SAMHSA, our model programs where we're seeing significant declines in one-year initiation rates of 10.9% on average. These are from the best model programs. What I'm showing you here is the current situation of use, even our hodgepodge prevention that's kind of embedded in here. If we were able to implement model prevention programs in middle schools in the US, the effects on use rates among 18, 19, and 20-year-olds doesn't get affected much, nor does heavy use, and these are our best programs. Does that mean that we shouldn't do prevention? Absolutely not. Drug prevention is cost-effective. It does have an effect, and it's very cheap to implement. In earlier work led by John at RAND, we showed that the average cost per student of implementing the best model program is about $150 per student. Most of those costs coming from the time we take away from teachers in school teaching other important topics like math and science. our most conservative estimate of the benefits of prevention were twice the cost. So model drug programming can be very beneficial. The problem is the effect size is fairly small, and communities have a really tough time implementing our model programs. We have science showing the best way to do it, and when we take it to the communities, it's not being implemented with high fidelity and to the level that it needs to be to get the measly 10% decline in initiation in 1 year. There's lots of reasons for this. Researchers at RAND and others have looked at this topic, and the problems have to do with the fact that we don't have a single agency providing prevention to all the programs across the country. We have different agencies that have different pet projects, different pet programs targeting maybe in this case drug driving, or in this case no use, abstinence, or in this case just not escalating use. And we don't have a clear goal, a clear standard, and we aren't holding programs accountable to achieving those goals. So if we're going to bank on prevention, we need to give our communities the tools to be able to do it better and get the effects. And we need to figure out how to get those effects sustained. Prevention scientists are working on this. This is not an impossible problem. But if you look at the problem today, prevention today, that's the status quo. So if we're not going to immediately be able to prevent our way out of this, we've got ballot initiatives right now considering legalization. We have lots of evidence the price will fall substantially, and significant evidence that even our best prevention programs are not going to delay initiation. What can we expect to happen to consumption? Some people have tried to answer this question by looking at the medical marijuana laws to see what has that done to consumption in the states that have them. For those of you who might not be familiar, 17 states in the District of Columbia today, as of January 1st, 2012, I say today, beginning of this year, had medical marijuana laws on the books, the orange states. What's important to consider is that if we look at the average annual prevalence of marijuana across the United States, as is shown in this graph, the orange and red states are states that have higher levels of annual marijuana prevalence than the national average. The ones that are white and light yellow are actually below national average. What you'll notice is the orange and red states here, mostly in the west and then in the northeast, closely mapped to the states that have medical marijuana laws. So the fundamental scientific question is it the laws that are causing this, or did the states that have higher levels of use, are they just more able to pass the medical marijuana laws? That's the scientific question that we would really like an answer to. And if you are an advocate with a particular position on the limited scientific research that's been published, you can find a study that gives you the answer you want. We have published literature that suggests that they're positively associated with use, and literature that says they have no association with use. And it's not purely a function of good and bad science. There's lots of hypothesized reasons for why the literature is mixed. One that we are investigating carefully is something that John has already hit on before with the legislation bills. These are not simple 0-1 dichotomous indicators. These medical marijuana laws are not all the same. They're not homogeneous, and they certainly have not been static. When I say they're not homogeneous, these laws differ in a number of important aspects that may or may not be associated to use recreationally, whether it's by youth or by others. Whether they were passed by voter referendum, whether they were passed by a state legislature, whether or not they require patients and caregivers to register, or they just suggest that they do, those are elements that may or may not matter. Things that are likely to matter, at least in theory, are how many medical conditions can you use marijuana for. If you can use marijuana only for a number of limited things, it's not as likely that people can go in and pretend those limited things unless they are really good at faking it. If you have on your law books that you could use it for general pain, that's really hard for doctors to identify in normal clinical settings, let alone for this purpose. So it's easier for recreational users to get in under the radar. Similarly, home cultivation might provide it for people at home, for the patient, but it also makes it available to anybody else who's in the home. Medical dispensaries provide a practice for anybody who gets a medical card. But if, again, and people can get a medical card by having general pain, that's not as narrow as it would otherwise be if it's for specific conditions.